The Trump administration has released new guidance on Section 1332 waivers. This is actually coming out of two departments, the Centers for Medicare and Medicaid Services through HHS and the Treasury Department. It grants states flexibility, this flexibility word is coming up again, and how they write Section 1332 innovation waivers. It's designed to help states create alternatives to the Affordable Care Act. We're going to refresh our memory on what 1332 innovation waivers are right now, and then talk a little bit more about how this new guidance will change that. But in the meantime, it is being called the State Relief and Empowerment Waiver. 1332 waiver guidance has now been renamed. There's been a lot of renaming coming out of this administration, and we'll talk about that more as well. This is actually under the authority of an executive order that President Trump signed on day one, where he said he's going to give agencies instructions to relieve states of the burden of Obamacare. And in so doing, they're supposed to find ways to give states some flexibility around the harsh requirements of Obamacare. This guidance coming out of CMS and Treasury is answering that call. It's saying we're going to give states a way to rewrite insurance rules to get around the burden of Obamacare, implementing coverage plans that don't follow Obamacare rules. Here's a quick refresher on what 1332 does now. It's the section of the Affordable Care Act, Section 1332, that creates innovation waivers. Right now in the Affordable Care Act, states can ask permission from the feds to add or replace key sections of the Affordable Care Act to improve the delivery of insurance services in their state. A lot of states are doing this right now with reinsurance waivers. It was also envisioned as being the way that states could implement a single payer system to say we want to change or tweak key sections of the Affordable Care Act that would allow us to offer health care for all in our state, or key sections of the Affordable Care Act that would let us create a reinsurance mechanism to relieve the high cost patients from some of the burden of that high expense. It only could happen if conditions were met. And the word guardrail appears for the first time when you're talking about conditions that have to be in place to protect the intent of the legislation. And so guardrails that have to be met if you're going to do a 1332 waiver are the guardrails of affordability of coverage, comprehensiveness of coverage, and budget neutrality. You can do an innovation waiver, but your coverage has to remain affordable, it has to be comprehensive coverage, and you have to be budget neutral when you do that. That's the way that 1332 works now. The language says a waiver can be granted if the coverage will be at least as comprehensive and affordable as under the state plan and cover as many people. That's 1332 now. So you can see those guardrails being worked into the language of a waiver can include some changes to the Affordable Care Act, but it has to be at least as comprehensive and as affordable and cover as many people. That's where we are now. The new guidance coming out of the Treasury and CMS changes this, and it says coverage needs to be offered to at least as many people, but it does not need to be similar in affordability or comprehensiveness. So at first blush, you would think, well, that doesn't pass the straight face test at all. The guardrails just completely disappear. Well, that's because they redefine the guardrails. They're saying it doesn't have to be the same coverage offered to everybody. New coverage can be defined by the state, and in fact, the statute itself is even silent as to the type of coverage that is required. So the new guidance essentially makes many new definitions. And this is what I referenced before when I said you're going to see a lot of redefining going on in this guidance. Let's start with how they define access to coverage. The new guidance no longer looks at the actual coverage purchased by each individual. They say, the feds say, the guardrails are satisfied if someone enrolls in a less comprehensive plan, as long as there was one plan in the state that complied with the Affordable Care Act. Then the consumer can choose any plan they want. That plan doesn't have to be comprehensive coverage that they sign up in. This is a total switch from the way that the Affordable Care Act has envisioned access to affordable and comprehensive coverage up until this point. They also eliminate the focus of vulnerable populations. States will look at populations as a whole, even if it reduces the comprehensiveness of coverage for people that are considered vulnerable, such as elderly, sick, or low income. This means that states can provide access to less comprehensive, less affordable coverage as an additional option for residents to choose, and choice here is used flexibly, as long as a comparable number of residents are projected to be covered as would have without the waiver. So if your number of people insured doesn't go down, you can offer any kind of plan that's not comprehensive as long as people have something. So the something is also what's being changed. So you could see how this would not work under the current definition of insurance in the Affordable Care Act, because insurance is defined as comprehensive medical coverage. Well, so this regulation had to do something else. It had to change the definition of coverage. So not only did we redefine access to coverage, we've redefined coverage itself in this guidance. The waivers no longer need to include coverage that qualifies as minimum essential coverage. That is one of the key ground rules of the Affordable Care Act, is that coverage that is offered must cover minimum essential coverage. Here, coverage doesn't have to. It can follow this section 45 CFR 144 definition of coverage, which, as you may recall from some of our past videos, was redefined to include things like short-term insurance, limited duration plans, association health plans. All those things that weren't ever considered insurance before are now considered health insurance coverage for purposes of this regulation. So if a state offers a short-term health plan, that satisfies the coverage requirement. There have been a couple other changes as well. Remember that guardrail language that it appears in the Affordable Care Act now for Section 1332 waivers? There have been changes through this guidance made to the guardrails of comprehensiveness and affordability. Some plans should cover essential health benefits, but states can decide what those essential health benefits are now, and making coverage affordable for some but more expensive overall is now allowed. So there's no longer this look of affordability thresholds as there was before. It also allows, and this is just unusual, but we saw this coming through some of the direct enrollment language coming out of this administration last year, it allows state-specific changes to what people see on healthcare.gov. So if states have their own marketplace, the state-run marketplace, they can keep doing whatever they're doing, make any changes they want. States that use the federally facilitated marketplace, healthcare.gov, have usually had to follow the same format and guidance as everybody that sees healthcare.gov across state lines. Now, this guidance says, states, if you want to redirect people when they hit healthcare.gov, you can. You can do more of a direct enrollment arrangement, which could take people out of the marketplace and to specific insurer plans to make their decisions. Another way to introduce short-term association limited duration plans into the options of what people may see, perhaps. You can bet that's the way that they're going. Now, the state law that implements 1332 waivers, that rule that's in the 1332 waiver right now, is going to be changed as well. So there is a requirement that if you're going to be a state that implements a 1332 waiver, your legislature has to sign off on it and your governor has to sign it into law. That guidance has been broadened here by saying, you know what, we no longer require new legislation. If you've got something on the books that says we're going to implement the Affordable Care Act, you're pretty much 90% of the way there. You don't need a new piece of legislation to get vetted by your Assembly and Senate. You can just go with that. There are a couple other little benchmarks that they're going to be looking for, but the authority given to states to implement these without legislative approval that's very specific has essentially been waived. So that's a lot of information. Let's go over this with a quick summary of what the new guidance is doing. It's allowing states to essentially set up a parallel insurance market, one that follows the Affordable Care Act as it was written the way that we're looking at it today, and one that looks very different with new definitions of coverage, one that looks at short-term plans as being coverage, one that looks at different definitions of affordability and comprehensiveness. The impact which benefits insurance plans can cover is going to be changed. The priority is going to go to the association and the short-term plans, and guess what? States can decide how subsidies are going to be rolled out and how much money people can get. You could have a system in a state where people buying short-term plans could get bigger tax credits than people buying comprehensive coverage. That could just be the way that the state decides they're going to compensate people for the coverage that they buy. So that means that ACA subsidies could be used for what are considered non-compliant plans. People buying short-term plans could get more assistance than those buying comprehensive, and states don't necessarily, in this whole new parallel insurance market, don't have to comply with pre-existing condition protections, essential health benefits, and as you can imagine, many advocates are expecting litigation will follow. This was not the intent of the Affordable Care Act to create side-by-side insurance markets because it totally sidesteps the individual mandate. It sidesteps guaranteed availability, affordability, and all of the other mechanisms that they've been fighting for this whole time. We're now creating a way to sidestep the mandates of the Affordable Care Act and promote skimpier insurance plans like the short-term plans that the President and the administration have been pushing. What are the concerns of this? Well, there are many, and they're the same as the concerns of short-term plans and association health plans being implemented in the first place. When you create a parallel insurance market, you're pulling people out of that comprehensive insurance market. Typically, it's the healthier, the wealthier that are going to be going into these skimpier plans, the people that feel like they just don't need the insurance to be as comprehensive and cover everybody else and pay a little bit more in premiums to do it. So you're pulling the healthier and the wealthier out of the Affordable Care Act marketplace, leaving that as your high risk pool. That cost continues to go up. Those are the sicker people, pre-existing condition people clustered together without the healthier, the younger, that can help spread that risk. So it's going against the basic concepts of insurance. You're pulling people out of the pool, creating two pools instead of one big pool, and risk is going up in one and risk and cost is going down in the other. This is encouraging states to tailor their insurance system towards the middle and higher income consumers, and the ACA marketplace overall continues to get sicker. If you're saying pieces of this sound familiar, you're right. As I was reading through sections of the guidance, I was seeing language that we had seen before, and I had to go back and piece together where that was coming from. It was coming from bills that had been introduced in the U.S. Senate and the U.S. Assembly that all failed. And we're talking about Graham Cassidy, Heller Johnson, the Cruz Amendment that prioritized consumer freedom over all other elements of the Affordable Care Act, and that piece of legislation called the Better Care Reconciliation Act, all attempts to repeal and replace the Affordable Care Act. Well, they couldn't get passed legislatively, so this guidance is a way for the agencies to just push those elements into the marketplace itself without legislation. The pieces that we're seeing in this guidance come directly out of the failed legislative efforts, and they are now going to be implemented. The new guidance is effective immediately, and by immediately we mean October 22nd. That doesn't mean you're going to be seeing states changing things overnight. This takes time. If you're going to create a whole new insurance market that's parallel to the Affordable Care Act, it's going to take time. States actually do have to do a lot of legwork to see what that's going to look like, how they're going to define essential health benefits, how cost and savings and affordability is going to work, who's going to be eligible for tax subsidies, how that's going to be administered, and what will people see when they log into healthcare.gov. That's going to take time, and most people are projecting 2020 is when we'll actually see any changes. In the meantime, you can comment. This is a regulation that is being proposed as guidance. It is effective, but it does have a public comment period of 60 days, which means up until 5 p.m. on December 24th, you can share your comments with the feds on this change to 1332 waivers, and they have to read it. Doesn't mean they have to act on it, but they have to read it. Regulations.gov is the website you can go. You can also submit a letter, and we give you the address. We're going to put this in the detail below as well of where you can submit your comments. It is very important that you give the reference number. We bolded the reference number on the slide. Make sure that is included. There is a lot of guidance and a lot of proposed rules out there now that are accepting public comment, and you want to make sure that your comment is being attached to the correct regulation, and that's what this is. So make sure that that reference CMS number that you see on the screen is included in either your electronic comment or the one that you send by U.S. mail, so that they can get the full impact of your voice on what this guidance looks like. You can read the guidance yourself. You can read the entry in the Federal Register where the guidance is formally published as of October 22nd. And you can also read the long press release that CMS sent out saying they're really happy with the work they're doing on giving states flexibility. If you have comments you want to share with us, you can send us an email. You can visit our website, healthwatchwisconsin.org.